Okay, so Richie, thank you so much for giving your time up to appear on the podcast.
Thanks very much for having me, Johnny. Happy to be here.
So, just for people who aren't aware of who you are, what it is you do, could you just give us a brief overview of those things?
So my name is Richie Kirwan, and I am a nutritionist and a postgrad researcher in Liverpool John Moores University. So I'm doing my PhD research there, and I'm looking at basically how I'm looking at a population called cardiac rehab. So people who have had some sort of a cardiac event before, so it could be like a heart attack, or they might be at a really, really high risk of that. And what we're trying to do is basically increase their muscle mass and improve their diet. And we want to see if that will have an effect on their risk of having another cardiac event in the future.
Hmm. Brilliant, and that's exactly what we're going to talk about in today's episode, which is
Cool.
fantastic. And so I mean that leads me to the first question. Then I guess is that idea that you've set off this paper to think, will this reduce people's risk? How would people measure that risk? What kind of factors are people looking for when they're thinking about relative risk of having a cardiac event?
So it's tough when you're talking about cardiovascular disease because it is something that, we have risk that builds as we get older. So it's very, very hard over a short amount of time to look at risk. So there are some studies that have gone on for years, and they actually look at the rates of somebody contracting a disease or having a heart attack. We're not going to do that because it's going to be somewhat short term. So we need to look at metabolic markers of that
Mhm.
disease. So we're going to look at some of the standard ones. So things like we're going to look at cholesterol profiles. So LDL, HDL, total cholesterol. We're also going to look at cholesterol subfractions. So LDL subfractions. So within LDL cholesterol, we've also got different types of LDL cholesterol. We're going to have a look at those as well. We're going to have a look at things like blood sugar, insulin sensitivity. We're going to have a look at long-term blood sugar, which is called HbA1c, blood pressure, and then a few other factors that are kind of related to heart health. So things like people's body weight, waist circumferences, BMI, things like that, and a whole host of other factors that we're going to look at too.
Cool. Yeah, as you said, you've kind of got to like tick all boxes, and I guess you find with a lot of metabolic diseases that a lot of the uh, risk factors kind of play into one another, don't they? A lot of these things with like diabetes, heart disease, you kind of feel like you're crossing off the same boat. It's almost like a risk ratio for a metabolic disease in general.
Absolutely, yeah. And so there is, the condition known as metabolic syndrome, which is basically it's basically everything that can go wrong with your metabolism is going wrong. And
Mhm.
it's something that is particularly prevalent at the moment. So it's what we see in metabolic syndrome is we see impaired glucose function, we see impaired triglycerides and blood lipids in general. We tend to see increased blood pressure. And all of these conditions come together and they basically make somebody metabolically much more unhealthy and much more likely to suffer from some sort of metabolic disease in the future.
Sure. And so for those people out there who are, because people train and eat for different goals, and a lot of the time they come down to aesthetics, we're talking about weight loss or muscle gain. And as you said there, weight loss plays a huge part. And so talk to me a bit about why weight loss would be such a huge part in reducing these risk factors for a lot of people.
So there are a lot of different reasons. I was actually speaking with Dr. Nicola Guess quite recently about her research into it specifically. And one thing that happens with weight loss, particularly significant weight loss, so if we're talking something over 10 or even 15% of body weight,
Hmm.
is you see an increase in insulin sensitivity. And when you have an increase in insulin sensitivity, you've suddenly got improvements in how we handle glucose, which is a major risk factor for something like diabetes. We also see huge improvements in things like total cholesterol. We see a great reduction in LDL cholesterol. And usually we'll see, depending on the type of diet somebody follows, you can see increases in HDL cholesterol. So improving their cholesterol profile. And we know that LDL cholesterol is a huge risk factor for coronary heart disease.
Hmm.
Then we see a massive drop in blood pressure as well, which is another risk factor.
Of course. Yeah. So and we're obviously talking about people who are coming from an overweight to obese category. I guess people who are at a normal body weight have already got that kind of thing in check, more or less, I guess, from that point of view.
More or less, yeah. So it does depend on the condition you're speaking about, and I don't want to speak too much outside of my own kind of field, but like
Of course.
in diabetes, for example, you can have people who are normal weight. And I'm using normal weight. I think the word weight there is particularly important,
Of course.
because you have people who are a normal weight or a normal BMI, who can be suffering from type 2 diabetes, for example, and
Mhm.
weight loss can still have a benefit on them because they may have, for example, a higher level of visceral fat, which is fat around the organs. And we know that visceral fat is metabolically not particularly good for people's metabolic health. So if even that person who is a normal weight loses a little bit of extra weight, and potentially increases some of that muscle mass, that improves their body composition, they
Mhm.
can get healthier as well.
Yes, and I guess that's why we have that idea, don't we, of people who are, of, as you said, normal BMI, who are actually technically unhealthy, because although they might have maintained a stable body weight, they've got low levels of muscle mass, high levels of visceral fat, poor diet quality, no exercise, that kind of thing. Even
Absolutely.
though, even though they don't need to lose weight from a BMI perspective, they almost need a body composition shift. And I guess that's why you've chosen to look at specifically resistance training as well within your research, because you
Mhm.
believe then that humans, I guess, are designed to move weights.
Yeah, so I suppose like to give a little bit of context to it and just to kind of build on what you said there. Um, so in, let's say, a cardiac population, so a population of people who've suffered some sort of a cardiac event,
Mm-hmm.
if we go by BMI, we can actually see something called the obesity paradox, which is people who have a higher BMI in a cardiac population actually have a lower rate, a mortality rate, a lower risk of dying. So that's kind of counter to everything that we would think. We would all assume that, if somebody's overweight and they're a cardiac patient, that they've got a much greater risk. But what we actually think it is that their BMI is higher, but it's because of a reduction in muscle mass and an increased amount. So we have individuals whose their lower BMI means that they've got a greater risk, and that's because they've got a lower amount of muscle mass and a
Mm-hmm.
higher percentage of fat mass, and that's putting them at a metabolic disadvantage when it comes to the other individuals who may have a larger amount of muscle mass. So we think that body composition is plays a major role in these conditions. So that's why in our study, what we want to do is we want to see is if we can increase lean mass, so muscle mass,
Mm-hmm.
in these individuals who have low muscle mass, so who have sarcopenia. So sarcopenia is a condition that basically it's the age-associated loss of muscle mass as we get older.
Of course.
And we want to see if we increase muscle mass in these people, will that improve some of their metabolic markers and their metabolic risk markers for cardiovascular disease in the future?
Yeah, fantastic. Yeah, and I mean, we should talk probably more about that sarcopenia, because obviously it's almost people can suffer heart attacks at any age, but it's one of those where it's kind of deemed almost an older person's route, shall we say, out of the world, for want of a better word. It sounds pretty dire, but and it's one of those where sarcopenia, I think, affects more older generation than people realize, and I don't think there's that much around preventing it and protecting from it.
Yeah. So the interesting thing about sarcopenia is, so everybody's aware of it in that it's not unusual for us to see somebody who's older and as they get older, they get smaller and frailer and weaker.
Mm-hmm.
And we just think of it as, that's just a natural part of aging, that just
Sure.
happens.
Yeah.
The funny thing is, so sarcopenia as a disease was only classified, or its diagnosis was only classified as a disease a little over 2 years ago. So it's
Oh, right.
really,
Wow.
really recent. So
Yeah.
obviously the condition sarcopenia existed, and we had that name, but it was only given an official classification a couple of years ago. And one of the reasons for that is it's not easy to classify. So if we go by one of the standards that's used at the moment, so there's a group called the European Working Group on Sarcopenia in older people. Really great title. Science.
Yeah. Yeah.
So they've came up with a set of criteria for individual to basically to diagnose sarcopenia. And what it
Mm-hmm.
was is your appendicular muscle mass which is the muscle mass that's on your arms and legs, over your height squared. And that's measured using DEXA. And if your muscle mass is basically 2 standard deviations lower than a healthy young population, that classifies as sarcopenia. They also have a strength measure in there, so using grip strength to define it. And that's not easy to measure, because a DEXA scanner is one, it's really hard to find them. You often only find them in exceptionally big hospitals or in university campuses. They're expensive to do, and they're just not part of common clinical practice. So it's not an easy disease to diagnose. I think using strength tests for it is a really good way, because if you have a grip strength test, it's very, very quick, and it's a kind of piece of equipment every clinic could have. And the interesting thing about sarcopenia is, so sarcopenia itself is the loss of muscle mass, so muscle size as we get older. But what's probably even more important than the loss of mass is the loss of muscle strength and function, and that's called dynapenia. And that actually seems to progress even faster than the loss of muscle as we age.
Wow. Yeah, and as you said, it's one of those where people have been aware of it, but the classification of it being a disease has only been quite recent. I think it's also the idea of it being preventable is what is almost new. Like, people were just kind of accepting that this is just, as you said, something that happens when you get older. Like, I always remember older people seeming like shorter, and you're like, have they shrunk, or like, what's going on?
Absolutely.
And so for people who are approaching like the back end of middle age and then approaching sort of 50s, 60s, what should they be thinking about with preventing this, and therefore trying to stay as metabolically healthy as possible?
So what I'd say is, even before that kind of 40s or 50s age group, I say
Sure.
get in early, and basically start using your body.
Yeah.
So like, if you talk about some of the causes of sarcopenia, where the main one is probably inactivity. So people just aren't being active, and as people get older, they become less active. And I think it's common, if somebody retires, they're expected to kind of put their feet up and just chill out for the next 30 years until they die or something like that. Waste away to nothing. Which is not what people should be doing.
I think they go to Florida.
Yeah, that's it. Florida to die, right?
Yeah. Just Florida's just one big retirement home and then a couple of amusement parks at one side.
Yeah, so that's probably, like, if you were to set up like an anti-sarcopenia clinic, Florida is
that's the place.
Johnny, you've given me a fantastic idea. Right? Okay. Anyway, let's not publish this podcast. This isn't going out.
I'll cut this out.
So that's one major issue, is that people are just not being active, and they should be. Another potential reason for it is something called anabolic resistance, which is, so if you're young. What, assume you're in your 20s?
Yeah, nearly 30, but 29. Yeah,
it still counts. Okay,
it counts.
So you're young. If you eat, let's say, a dose of protein, maybe 25 or 30 grams of protein, you're going to probably high quality protein. You're going to stimulate muscle protein synthesis. You're going to stimulate your muscles to start growing and repairing themselves quite robustly. But if you give that same dose of protein to an older adult, somebody in their 60s or 70s, anabolic resistance means that they're not going to have the exact same effect. They're going to have a reduced effect of muscle protein synthesis. So they're not going to stimulate muscle growth as much. They're not going to stimulate muscle maintenance as much. So what we know is that a higher dose of protein in those individuals is actually beneficial, and that can actually help them to get that same robust muscle protein synthesis response as a young person. It just takes a lot more protein. So those are two big reasons for it. So I suppose if we go back then to your original question, what can people do? So if you're young, just stay active, and in your youth, build as much muscle as possible, because it does become harder as you get older. And I suppose just on that, anabolic resistance isn't just to do with the effect of food or your dietary intake. There's also an anabolic resistance effect when it comes to exercise. So older adults need more intense exercise to produce a similar kind of stimulus for muscle growth compared to young people.
Sure.
So in your youth, build up a good base of muscle. Stay active. Do some form of resistance exercise that keeps your muscles nice and strong, and then maintain your activity levels as you move forward. And as you're getting older, you may need to start increasing protein intake too. And preferably from higher quality protein sources.
Yeah, brilliant. No, I think that's a great summary of that. And it's perfect as well, I think, to talk about that training and activity side first of things, of like preventative measures and having that, even if you're now listening to this and you're an older adult, it's not like too late for you to start. It's a case of you need to get moving and start, moving resistance in whatever way that you can. I think if we double back then to diet, like, specifically within your study, you're looking at the Mediterranean diet's effects, and why have you chosen that particular lifestyle?
So, because we're working with the cardiac population, we want to provide them with the best chance of improving their or reducing their risk of cardiovascular disease.
Mm-hmm.
And so the Mediterranean diet recently has been getting quite good publicity. So in the last like decade or so, there were a couple of really, really interesting papers, about last 2 decades, let's say, that were published. One of those was the Lyon Heart Study, and the other was a study called PREDIMED. And both of those were looking at Mediterranean diets. And the Lyon Heart Study looked at what's called secondary prevention. So that's what we do. So we're looking at a population. They looked at a population who had a heart condition before. They gave them a Mediterranean diet, and it showed that the Mediterranean diet reduced their risk of having another cardiac event in the future. And then the PREDIMED study is a primary prevention study. And what they did is they worked with a population that had never had a cardiac event, but they did have metabolic syndrome. And as we kind of mentioned earlier, metabolic syndrome does put you at risk of developing some form of cardiovascular disease or diabetes like that in the future.
Mm-hmm.
And the PREDIMED study also showed that they had a considerably reduced risk of developing a heart disease from that Mediterranean style diet approach. And actually, I did my master's degree in Barcelona, which was one of the centers for the PREDIMED study. And I worked with the PREDIMED team on my master's project. So one thing about my master's is I think we were definitely brainwashed into loving the Mediterranean diet.
Sure.
But, there's a whole lot of evidence to back it up as well. So it is a very potentially beneficial dietary pattern. And the reason I say the word dietary pattern is, so if I could not use Mediterranean diet as a word or a term, I probably wouldn't, because I think if you give it a diet a title, it makes it almost it gives it corners, it gives it edges, it gives it a frame in which it's confined.
Oh, sure.
That might be a little bit restrictive. So it's a dietary pattern in that we think of, okay, it's got a high intake of fruit and vegetables. Mm-hmm. It's got a high intake of whole grains, legumes, fish. It's got a moderate intake of dairy products. It's got a reduced intake of red meats, saturated fats, and then processed sweet foods and things like that. Mm-hmm. And then, loads of olive oil and the odd tipple of wine here and there as well.
Great. Yeah, and it's funny that you said like you wouldn't really want to call it the name, but that's what people refer to it as, isn't it? And it's fad diets and gimmicks aside, it's just the kind of pattern of the kind of foods they're going for. Mm-hmm. And I think if we look then at that classification of foods, what do you think? And we can touch on the different points, of course, as you said there. You've got almost higher protein because of the way that they're eating. You've got more plant-based foods with fruit and veg. You've got more fish, more. Therefore, poly and monounsaturated fats, less saturated fat. So what would you say, is that combination of all of those things that are such a game changer, or are there like specific things that you would pick out that makes the real difference when we're talking about cardiovascular disease in general?
So there's a couple of parts to that. So I'm going to say that everything in that diet contributes to the reduced risk. Mm-hmm. When you're looking at a dietary pattern, you can't, just because of the way those studies are designed, you can't isolate what nutrient is causing the beneficial effects. Mm-hmm. And that's a good thing and a bad thing. It's a bad thing if you have a reductionist view of nutrition and you say, okay, I want to find what nutrient I should be taking to reduce X condition or whatever. Mm-hmm. The only problem is we don't eat nutrients, we eat diets. And from a pragmatic perspective, if you're using a dietary pattern, or even like an exercise regime with a dietary pattern, you don't know what's causing the effect specifically, but you can say that it has an effect or it doesn't. And then that makes prescription of that diet or that dietary pattern a lot easier. In the PrediMed study, a huge amount of research went into looking at the effects of unsaturated fatty acids. So there were two arms of PrediMed, and one of those arms, so both had Mediterranean diets. One of them had a Mediterranean diet supplemented with nuts, so they got a mixture of walnuts and almonds and things like that. And then the other one was supplemented with olive oil. Both of those, compared to the control group, which was just on a standard low-fat diet, reduced their risk of cardiovascular disease considerably. And they think that one of the main reasons was a reduction in saturated fat, which was beneficial, and not just reducing saturated fat, but replacing it with the unsaturated fats. So some of that was polyunsaturated, and most of it was monounsaturated in the olive oil part. And there's a few different reasons that could happen. One of them, which is particularly cool, and this is something people don't talk about a lot, but if you were to look at some of the outcome measures of PrediMed, it shouldn't have worked.
Right.
So if you look at for example, LDL almost didn't decline at all on the PrediMed study. It wasn't really statistically significant. So people were like, well, if LDL didn't go down, then what happened? So there were some changes in LDL in that. So if the people who were taking the olive oil in their diet, so it was extra virgin olive oil, and we know extra virgin olive oil is really, really high in polyphenols, which reduce inflammation, they can reduce oxidation. And they found that the LDL cholesterol in people who were taking the extra virgin olive oil, it had a reduced rate of oxidation compared to the people who weren't taking the olive oil. So that's one possible mechanism that it could be reducing cardiovascular disease purely by having a lower inflammatory effect on people. So that's one possibility. It's speculation at the moment.
Mm-hmm. It's so interesting, and I think it's important, as you said there, about the idea of it wasn't just the lowering of the saturated fat, but it was almost the replacing of saturated fats within the diet with these unsaturated fats, both poly and mono. And so would you hypothesize, I guess, that there is this idea then that actually it's not saturated fat so much is bad, but it's having too much of it and then skewing that ratio of fats that you are having within your diet that could potentially cause to this imbalance in cholesterol and other markers?
Yeah, so it's for some reason it's kind of controversial at the moment with saturated fat. So saturated fat, I would say, is definitely not benign, and like you said, an excess of it can be detrimental to health. So like the current kind of recommendations for it would be keeping saturated fat under 10%. And if you can, so one of the interesting things is if you look at studies where they replace saturated fat with different macronutrients, you have 3 different effects. So if you replace saturated fat with polyunsaturated fatty acids, you get a massive reduction in cholesterol. And that reduction in cholesterol can be related later to a reduction in risk of cardiovascular disease. If you reduce it with monounsaturates, it tends to go down as well. And then if you replace it with carbohydrates, well, there's 2 possible effects. If you replace it with standard refined carbohydrates, LDL can actually go up. But if you replace it with unrefined whole carbohydrates, it goes down again. So all 3 of those nutrients bring it down, but just to kind of different extents.
And to classify that then with this unrefined whole carbohydrates, you're talking more about like fruits and vegetables and then maybe, whole grain, fibrous carbs, that kind of thing, as opposed to refined junk food.
And legumes, things like that. Yeah.
Sure.
So replacing with refined, and see, it's a tough one if you're looking at dietary studies to say like, refined carbohydrates are doing this, but we can't say specifically, is it just because it's a refined carbohydrate? Well, depending on the study you're looking at. But you could also say people who have a lot of refined carbohydrates in their diet are probably going to have a pretty crappy diet anyway as well.
Sure.
So that's just something to kind of bear in mind when we talk about studies like that.
Yeah, of course. And if it fits your macros aside, it's one of those things, I guess, is if you're someone who's got the bare bones of a diet down, and then you're looking at like making things as optimal as possible, or you're trying to reduce risk ratios, then it's looking at things like, okay, what's my ratio of fatty acids like, and making sure that we always say to people, your diet should be like 80-20, 90-10 in terms of processed, unprocessed anyway, but it's just, I guess it's important for people to to hear this kind of data, especially if you're coming from someone who's got a family history of this. Your risks are always slightly higher. Like I remember last time I got my bloods done, I was told I had something like familial hypercholesterolemia, like where it's
Wow.
like I'm always going to be on the top end of my cholesterol despite being a healthy body weight and extremely active. And I was like, okay, but how can I move this down? And they're like, oh, we're not sure you can, but I mean, maybe I'll just take up the Mediterranean diet and then things will be good. Things will be sweet.
Yeah, it would actually be quite interesting, like, especially in your case too. So familial hypercholesterolemia is a very interesting condition in that it's used partially for studying the effects of LDL cholesterol on heart disease, basically, and how it affects it. So it would be kind of interesting from an N=1 perspective, because I'm not familiar with dietary studies on that condition, but it'd be interesting to see if you could kind of N=1 yourself and do a few before and afters.
Hey, why don't I just come down to your lab over in Liverpool and we'll just put through like a 12-week intervention.
We'll, as we say, we'll bleed and feed you. So
Yeah, exactly. And I guess you talked a little. We've talked a little bit about saturated fat, and so talk more about there in terms of we've got more and more. Well, actually now, because of the recent BBC headline, we've got almost conflicting advice on our sort of take on red meat and processed meat in particular. Can you just help us clarify the difference between the two for one, and also let's talk a little bit more about that headline because it seems quite funny to do so.
yeah, that was a great headline. A lot of people are up in arms over that at the moment. So yeah, let's talk about different types of meat. So meat is most definitely not a homogeneous compound. Not all meats are the same. Okay, and I'm going to say that this with caveats as I'm moving forward. So you can have a cut of, let's say, eye of round steak, which is pretty much the red meat equivalent of chicken. It's super low in fat, super high in protein. You can have a ribeye steak, which is a lot higher in fat, and then you can have some processed meats. So things like chorizo or salamis, or other basically strange meat products that are made from mashing up meat and usually mixing it with fat and a lot of salt, and then sometimes aging it. And they've got hugely different macronutrient breakdowns, and they'll have hugely different effects on your health. The recent paper that came out was it looked at a meta-analysis of different studies. Okay. And here, I'm not going to get into it too much. One thing that I think was ridiculous about the study was that the group who did it, their language in the study was horrendous, in that they were saying what they were saying almost like it was a guideline. They were telling people, yeah, you can continue on with your diet as such and such. But they had no kind of reason to give guidelines whatsoever. And because it was a meta-analysis, so meta-analysis, a lot of people talk about meta-analyses in the study of nutrition. And we kind of put it up there as being a really, really, so basically for anybody who doesn't know, a meta-analysis is is when you do a statistical analysis of a number of similar studies to try and get the overall result. Okay. And people often kind of hold it as being the pinnacle of what a scientific study should be. The problem is meta-analyses were originally developed to study pharmacological drugs.
Yeah.
And the thing with pharmacological drugs is you can do a really, really kind of well-controlled study with those, because you're looking at one thing. You're looking at a specific population. You're looking at a specific dose of a little tablet that you can give to people. And you can say, take that, and we're going to watch what happens to you. And then you can do a load of those studies, and they're all really, really, really similar. And that means getting kind of like an average from those studies using a meta-analysis is quite easy. When you're doing it with a nutritional studies, things get a lot more complicated, because no nutritional study is the same, or very few nutritional studies are the same. So even my study right now, it's going to be unique in some aspects of what we're doing with people. So I'm using I'm doing a high protein diet, but it's going to be a high protein Mediterranean style diet. And we want to look at how that affects cardiovascular risk markers. That could be very, very different from somebody who just does a high protein diet, or somebody who does a high protein diet but with a lower quantity of protein, or a higher quantity of protein, or using a different protein source. All of these factors come into play. Anyway, so I'm going off topic.
No, she's fine.
But yeah, so it's very, very hard to do that. And what we often find with nutritional meta-analyses is they tend to dumb down results. So what this study was looking at was whether reducing meat intake would reduce risk. And basically, they didn't find anything. They didn't find a risk that they considered worth worrying people about.
Yeah.
I'm saying that specifically like that because they said that there was a very, very, very slight risk that they saw, but they just said, you know what, it's small, don't worry about it.
Yeah,
okay?
weak was their words, wasn't it? Weak
Yeah.
grading.
And the issue with that is, okay, you know, I do not think meat is horrendously bad for people. I think excess of anything can be. But I think when you put out a paper like that, it's irresponsible because, like, you've seen all of the headlines, Johnny. They're out there and they're saying, "Oh, red meat, not as bad as we thought.
Yeah, it's fine.
All okay now."
Yeah, get the bacon back on the grill.
That's it. Exactly. You're going to have everybody doing that. Well, you know, red meat is fine. You know, give me that ribeye. You know, I'm just going to wrap it in bacon and then I'm going to have a few sausages with it.
The keto and carnivore guys were all rejoicing with their ways.
I said it to someone. I said, yeah, all the carnivore people are now well up on their pretentious high horses, which I'm assuming they're going to eat later as well. It's look, we have to be, and again, it's one study. We have to be very, very careful with the interpretation of any study. I think the people who wrote that study, they really, really were irresponsible in the way that they worded everything and the way they did their study. But yeah, that's besides the point. Meat in moderation is probably okay, but, like, you know, just giving people the green light to go crazy is
wrong. Yeah, it's that idea, isn't it? Of as you said, it's funnily enough, anything in excess will be bad for you, and the whole idea of a balanced diet seems to come roaring back around again. And in terms of cardiovascular disease prevention, maybe even, you know, balancing things as finite as fat intake as well, which is obviously super interesting for those that are listening. I guess, you know, a final point would be then, you know, we've talked a little bit about resistance training, we've talked a little bit about diet. With the Mediterranean diet specifically, you get sometimes these ideas of, like, there has to be this specific macronutrient ratio of like 30, 40, 30. And so what would your take be on that in terms of that ratio? Or is it just that idea of a theme of high protein, more of these types of unsaturated fats, fruits and veggies? Don't worry too much about exact splits.
Yeah. So to make it easy for the people who I'm working with, and bear in mind, like, so I'm working with cardiac rehab patients. These are people who are going to be in their, you know, their late 40s, 50s, 60s, 70s. So if I start talking about macro splits, people are going to kind of look at me funny and kind of throw whatever guidebook I give to them into the bin as soon as they leave. So you want to make it as easy for them as possible.
Yeah.
So I don't focus on that. What I do focus is on a few kind of key guidance. So, like, for example, the word calories isn't mentioned in any of the books, the guidebooks I'm giving out to my patients. What I am saying to them is, increase your fruit and vegetables. Okay. And I think that's one thing that any reasonable nutritionist can agree with. Increase your fruit and vegetable intake. Switch over your refined carbohydrates to more whole carbohydrates if you can. Add more legumes to your diet. Reduce the amount of fatty red meat that you're eating and eat more lean red meat instead. Or replace some of that with fish. And some of that should be oily fish. And then besides that, reduce your amount of refined product in general and reduce saturated fats like butter, margarines too. And then on top of that, we're adding in a specific dose of olive oil, and that's 4 tablespoons, because that seems to be what, that was what Predimed used. And kind of Predimed is like the granddaddy of them all now. So anybody doing a Mediterranean diet tries to follow Predimed. So it's like 4 tablespoons for everybody. But but that's what we want to do. So we're reducing their saturated fat intake and we're replacing it with that monounsaturated fat.
Sorry, I was literally just. It's fantastic. Thank you so much for like those summary of guidelines, because that was what I was pretty much going to ask. But I was just imagining the meme of Oprah being like, "Olive oil, you get olive oil. Everybody gets olive oil," and I just imagined that being created.
That's literally what we're hoping to do. As soon as we get a sponsor, we are going to be throwing out bottles of olive oil at people.
I tell you what, since after this podcast, I'm throwing away my fry light and just bringing back the bottles of olive oil and just thinking, hey, it's worth the hit in the macro for such a great cause of oil.
But here's the thing I'll say, like, obviously, look, we're saying get the olive oil in. We're trying to reduce fat from other sources. So yeah, their fat intake is probably going to go up. Hopefully, just because of the guidelines we're giving them, their calorie intake might potentially go down from other sources. So it'll be balanced out by the oil. We're not specifically looking for weight loss in this study. So yeah, you don't need to go crazy on the oil, Johnny. You've probably got a pretty good diet as it is.
I know, purely jokes aside, but no, I love that idea of focusing on resistance training and almost that kind of like diet quality and specifics. I think that would be really cool. So I look forward to following your work on it. For those people who do want to obviously keep in touch with you, the work that you're doing, where's the best places to send them?
Yes, so I have a website which I never update, which is bemorenutrition.com. So that's my company name. But I suppose I'm most active on social media wise on Instagram. So I'm just B_more_nutrition. Somebody got in there with the Be More Nutrition.
Yeah, got it. Yeah.
But you can find me on that. I also I'm active on Facebook. I've got a Be More Nutrition page on Facebook. Don't use that all that often, but Richie Kirwan on Facebook, you can find me that way. And then I've got my ResearchGate profile, which is kind of my academic profile for my studies, and whatever I publish goes up there. So yeah, you can just find that by searching Richie Kirwan on ResearchGate.
Nice one. Well, I'll link up to those in the notes, and thank you again for coming on. It's been a great conversation.
Thanks very much, Johnny. Really appreciate it.
Cheers.